Welcome to the Counselling Tutor Podcast, the must-listen-to podcast for students of counselling and psychotherapy. Here are your hosts, Rory Lees-Oakes and Ken Kelly.
Hi, I'm Rory, and with me, as always, is Ken. How are you, Ken?
Exceptionally well, and grateful to be here. This is episode 188 of the Counselling Tutor Podcast. Rory and myself are delighted that you've joined us today. And in this episode, 3 different topics, starting off with our student check-in, where we kind of visit some of the theory that you might cover on your counselling training course. And we're going to be looking at something of great interest to me today, and that's dual process model of grief. So we're going to be digging into that. Then Digital Counselling Revolution, that's our next section where we recognize that technology forms a part of how counselling is now consumed by our clients, delivered by our therapists. And today we're going to be speaking about something vitally important, because when we speak about digital delivery, we also involve in that the telephone, and we're speaking about attachment when working via telephone, specifically hidden attachment. What do we have to consider? And then we put our toe into practice matters, where we look at an element of practice. And today we are actually taking a peek into somebody else's practice, and we've got Martin Smith, who's going to be speaking about his practice in working with personality disorders. But let's kick us off with that student check-in, dual process model of grief. Now, Rory, grief, this is something that presents often within a counselling relationship, because all of us experience grief at some level at some time in our life, and very often it will form part of the narrative, the story that a client brings in.
Yeah, absolutely, Ken. And I think I'd like to say completely off the bat here that when one's working with grief, there are different models of working with grief, and sometimes the meta models that we taught, person-centered theory, CBT, TA, may not actually be a great match when you're working with someone with grief, because we're not trying to affect is a form of cure. We're trying to help someone in their process of loss. And I think it's a really interesting distinction that, sometimes when we're working with clients who are experiencing grief, we should really have a good understanding of the models of grief. And up till recent times, the Kubler-Ross model was the most popular model. And I think most people who've studied counselling will have come across the work of Elizabeth Kubler-Ross and the model of what's sometimes referred to as DABDA, which is which is a set of processes that people go through denial initially, then anger, then bargaining, then depression, and then acceptance. The trouble with that model, and a lot of people have observed and critiqued it, is that people don't go through those processes in the order that they're sometimes seen in the theory, or at all. So different models have come to the fore over the years. And the model we're going to talk about is the Strobe and Schutz model, which was published in Death Studies in 1999. And I think it's one of the most useful tools that a therapist can have, because it looks on loss as loss-orientated responses and restoration-orientated responses. So it's an oscillation model. And anybody who's worked with anyone who's had grief, and in fact, thinking of my own grief responses, we go through this oscillation, this movement back and forward, where we're thinking about the person who's, we've lost. We're feeling the emotions, the sadness, the anger, whatever emotion that is attached to the loss. But also we're oscillating into our lives moving forward, because we're forward-driven beings. That's how we are. So it's a really good model for a therapist to be able to assess where someone is. And I think critically, one of the things I like about this model, and when I did a certificate in grief studies a good few years ago now, one of the things the trainer said was that some people get stuck in between the oscillation. In other words, they're in total denial of the loss. And that is, again, another useful assessment tool. If someone is in complete denial about loss and they believe the person's going to come back or the person isn't dead. It can lead to rather psychotic presentations. So again, such a useful assessment tool. If you have a client who's really in that complete denial phase, it may be they need another form of support.
Yeah, I think what's important, Rory, is you kind of started off speaking about grief and the Kubler-Ross model, which is kind of, I think, known to many, including the clients. And this is the interesting thing here. If you kind of go onto Google or a search engine and put in a search for something related to grief, chances are you're going to get hit with results like the 5 stages of grief. Or if you kind of know the theory, then the Kubler-Ross model of grief, or DABDA, as you described it, Rory. And it's very much like I'm supposed to go through this, and then I go through this, and then I go through this, and then I go through this. So an expectation from maybe a client's perspective, if they're aware of that model, or maybe an expectation from a therapist model of trying to label what section is this person in, and they that means they've been through that section and they're about to go into the bargaining phase, or whatever that may be. And grief is individual. It affects each person uniquely and differently. I've experienced a number of losses in my life, and I can look at the losses. I've lost my father, I've lost my mother, and we lost our son when he was very young. And if I look at the different losses in my own life, they affected me differently. I handled them all differently. And I think that we need to recognize that somebody presenting with grief is a unique individual, and they're going to have their own process that they go through. Looking at this dual process model that you're bringing today, Rory, I really like it. And you've spoken about restoration orientated and loss orientated. And I just wanted to give a description of what that is. So if you're listening to this and you're not aware of the model, when we're talking about loss orientated, what we're doing there is that would be a focus on the emotional process of the loss of the person. So the client may present and speak about memories. I was thinking about them the other day, reminiscing, thinking back, yearning, wishing they were here. I look at the door and I almost expect them to walk in the door. We're talking about loss orientated. It's focused and on the actual loss, the person not there anymore. I couldn't stop myself crying. I was missing them so much. I had a dream last night and we were together again. And when I woke up this morning, I was imagining, as I was making my toast, that he or she was just in the other room. We're talking about the loss-orientated focus here. And then the other side of this is restoration-orientated. And what that is, it's kind of what unrest has been caused within the life of this individual from the loss of another person, that is not necessarily 100% related to who they were and the loss of that person. And it may be that person did all the bills in the house, and now suddenly this person is faced with bills that they don't know how to work it. They don't know the login details for the accounts. Maybe the person who is no longer around did all the cooking. And now this person is faced with the challenges of having to cook and learn how to cook. And it's a difficult place to be. It could be the childcare. It could be that the other person was the provider and brought the income into the home. And suddenly that is gone, and there are now financial issues and a need to find a job. And there are the two sides of the dual process model. We're recognizing that there is the loss orientated focus on the person that is no longer there, what that feels like emotionally and what that process is. But we're also recognizing that restoration orientated. Restoration, why? We need to rebuild. We need to rebuild the life and the missing part that was there. And I think that those are two really important areas to be looking at, and understandably that the client would oscillate between the two, understanding what they are as a counselor, understanding whether the client is within that loss-orientated focus or restoration-orientated focus is in service of the client.
Yeah, absolutely, Ken. Very well said. And as you said, it is a balancing act, and part of the restoration is the learning new skills and developing new skills. and even forming new relationships. I mean, how many times do we hear of someone who's been bereaved, who then goes and joins something? And I'm not saying that joining some form of organisation or club is a cure for loss, but it's a process of restoring oneself and restoring oneself in the world. And I think there's another aspect of this model which is sometimes forgotten, that there can be an aspect of journaling for clients who want a more active, directive approach, who actually ask, what can I do to help myself? A therapist could say, well, you could keep a journal, and you could keep a journal, down the line of, the loss side of it and the feelings that you've had, and also what you're doing, what the restorative side is. And I think that could be a very, very useful intervention, because it gives a client a real indication of how they're coping, how they're surviving in the world, and also how they're moving on into their lives. Because I think that bereavement work is as much about acknowledging the loss and acknowledging the pain, but also acknowledging the movement into someone's life, because they're the person who's left behind. They're the people who are going to move into their lives and restore and regain their lives and start living their lives again.
I think that journaling, sharing the model, I guess, with the client, so that they understand the two sides, the restoration orientated, the loss orientated, so that they're able to see that. Journaling it, as you've suggested, Rory, what that can do is it can kind of show if there's any imbalance there. And I'm using an example here of I'm going to say a child who is maybe 17 years old, and the father passes away, and that child going, I've got to take that partner. I've got to stand up and be the man of the house. I don't have time to grieve. I haven't got time to wallow in sorrow. I've got to get on with it. I've got to get a job. I've got to provide. And that would be very much an imbalance towards the restoration orientated side. And we may, as therapists, suggest and recognize that, and then maybe gently inquire, how are you under all of this? I see you carrying that, making all those changes, standing up, but what's happening inside? And we can gently, I guess, encourage, or at least invite, that there are two sides of this, and it can be a very one way centered focus. And I'm looking at myself here. When we lost our son, he was 3.5 years old. It was a terribly dark time in our home, and my way of coping was to throw myself into work. The way that I'm going to sort this out is I'm going to provide the structure and at least normality outside of the loss. And I focused myself and threw myself into work for a good year and a bit, excuse me, before I took a breath, took a pause, and realized that I was falling apart because I hadn't looked at the loss. I'd been so busy trying to hold everything together and fix it and be the strength for my wife through this difficult time, that I hadn't looked at the loss myself. And it needs to be examined. That's the one thing. It needs to come out. It's going to come out somewhere at some time.
Yeah, absolutely, Ken. And we have a handout on this. So if you go to counsellingtutor.com, go to podcast 188, that handout is there for you, and it overviews the dual process model. And as we move away from this topic, I would say that the bereavement doesn't have to be just the loss of a person. It can be the loss of a job, loss of health, loss of circumstances. There's a huge amount of, when we think of loss, sometimes we automatically think of, a loss of a person, and that's fine, because that is definitely part of it. But loss appears so often in the therapy room, and I think that model is a useful model for whatever loss that someone's having, because as Søren Kierkegaard said, life has to be viewed backwards but lived forwards.
Yeah, I like what you've said there, Rory, and I think you've tied it up beautifully. And as you were saying it, I was kind of thinking how what a good fit it might be for breakdowns in relationships, because it's the same kind of idea that you may have lost a part that kind of looked after the finances or the cooking or the DIY jobs around the house, and you've got the loss of the person it is. It's I think a flexible model worth having a look at. Get that handout, counsellingtutor.com, podcast tab at the top, episode 188. That's today's episode, and that super duper handout is there for you to download, and it is free of charge. Moving away from our student check-in, we move into our Digital Counselling Revolution now, where we're going to be speaking about attachment when working via the telephone.
Digital Counselling Revolution.
Working online brings many, many challenges, and a complete, almost complete, a different approach in some aspects of our practice. And one of the areas which is an area we need to think about is when we're working solely on the telephone. We talk a lot about the disinhibition effect, the work of John Suler, and the psychological idea that when we're working remotely, we become slightly distanced. It becomes a slightly surreal experience, and this can manifest itself in many, many ways. And one of the ways is, of course, attachment. If you're listening to someone on the phone, it's very likely, or it can be likely, that you may recognize that person from another relationship. We call that transference, and I've spoken about transference a lot on the podcast. But the idea that the person we're working with, or indeed if it's on the phone, are speaking to, are someone that reminds us of our past. And depending on what that relationship was, it can generate attachment issues. So, a therapist who may sound like someone's mother, and you come to the end of a session and, you book the next session, there may be a feeling of loss or abandonment. And we need to keep I was going to say an eye out, but if it's on the phone, an ear out for any attachment issues. And I'm a great believer in therapy in general, for therapists to have a radar of with their clients. If the client says things like "you remind me of," or "you sound like," I think that is a good time just to do some very gentle exploration of that, because it does speak to transference. And if you've got someone on the phone, maybe a long way away, they're working with you, that you remind them of someone, they're reminded of someone from their past, and the attachment that they've had with that person, when the therapy ends, it can generate some real difficult attachment issues.
Yeah, I think it's when you're working with audio only, and you kind of have this voice on the other end, maybe we kind of imagine who that person might be, what they may look like. And this is from us as the therapist point of view. The same is true from the client perspective. And it's always recommended, and we speak about this in our course, our certificate in online and telephone counselling course offered by Counselling Tutor. Interested in that? Go to counsellingtutor.com. The info's there. What we speak about is sharing a photograph of yourself as the therapist with the client, so that they have a picture in their mind of who they're talking to. So you've kind of pointed out what we kind of need to watch out for here, Rory. What I'm suggesting is that we look at ourselves as well for working on the telephone. What is happening in our imagination of who this person is? Do they sound like a frail person because their voice is, I don't know, maybe slightly high? Do they feel like a strong person because their voice is deep? And of course, keeping in mind, all of this is us transferring onto what we're hearing and using our imagination, our past, and I guess some part of our subconscious potentially colouring in between the lines. And we're looking for that to be reduced. We're looking for that to be reduced. And of course, that can happen in supervision, that can happen in journaling and looking at yourself. But I think being aware of it is interesting. And if you want to do an interesting exercise that is kind of linked into this for me, if you've ever heard an episode of The Simpsons, and I'm taking The Simpsons because they've been going now for way over 20 years, so I'm sure many people have seen an episode of The Simpsons. Jump onto YouTube and put in voiceover Simpsons and watch the actual people that do the voices for The Simpsons talking. And when I looked at it, I went, oh, that's so different to what I imagined. So I had created an imagination of who this person might be, and it didn't fit. And I wonder, looking at my own life, many times I've heard a voice and then seen the person and gone, oh, that's not what I imagined. And there's the trap. It's not what I imagined. When we're working with our client, the last thing we want to be doing is imagining. So that is 100% in our fantasy and our own frame of reference. We want to be in the client's frame of reference. So just recognizing that this potential pitfall exists, I think, is a great first step.
I would agree, Ken. And also, I think there's something quite biological almost about the human voice. If you think about it, most children hear the parent's voice before they actually see them, because most babies, their sight develops after their hearing, or so I'm told. And there's something about the human voice, the disconnected human voice. So many years ago, when I grew up, there used to be a radio program on the BBC called Letter from America with Alistair Cook. He was an English man who lived in New York, who spoke about things that happened in America. And what was really interesting is that eventually he died, and the program was ended. But the amount of outpouring of grief and sadness for this broadcaster was incredible at the time. And of course, he provided a fantasy figure. I think for a lot of people, his voice was almost semi-parental, almost very reassuring. And I think that is something that can happen in therapy, where the client can hear the. Obviously, there's the interaction between the therapist and the client, but also there's the sound of the voice, and I think that voice is where the attachment lives. It can take us back to childhood, and it comes back, as I've saying a lot on the podcast recently, that Richard Erskine quote: when the adults in the room, the child is always listening. And that's not super true when we're working on the phone, I think.
Yeah, it's really interesting. And when we were building the online and telephone counselling course and kind of looking at telephone, I did a lot of reflection of who I am, how I am on the telephone. And one of the things I picked up is I lived in South Africa for 30 odd years. And when I'm speaking to someone on the telephone here in the UK, maybe one of our customers in Counselling Tutor or something like that, and they have a twang of a South African accent, I feel a connection. I feel like I've got another line there of something we can speak about. That, and it's really interesting because it's just it is all generated by me. And I will never forget. Some years ago, I was in a Tesco in Warrington, and I could hear somebody speaking in a South African accent, and they were on a checkout. They were speaking in a South African accent. They were going through the checkout, and they were speaking to the person who was checking them out. So I heard it first, and then I made it my business to kind of go around and say, "Oh, hello, are you from South Africa?" Now, I'd only just come to the UK. I'd probably been here for less than a year at the time. So I was still bright-eyed and bushy-tailed when it came to South Africa. And the person stopped, looked at me and said, "I'm sorry, do I know you?" And there crumbled my imaginary connection and relationship with this person. I said, "No, sorry, I just heard that you might have a South African accent." They just turned around and walked away. And quite rightly so, a total stranger walking up to you and saying, "Excuse me, are you?" And but that was part of the learning for me of how you hear something, project something on it that comes 100% from self, check it out, and find that it is not shared coming the other way. So yeah, it's interesting from the point of view of us being a therapist working on the phone, and then also from keeping the eyes out and the ears out for how that is for the client, hearing our voice. What does that bring up for them? And how you might work with that, how you might explore that with the client. It's an interesting topic, and I think one that definitely requires reflection and thinking about of how you work with that if you do work on the telephone.
Yeah, absolutely, Ken. And just to end this, I have the same transference. If I ever hear anybody who's ever been in the military speaking, I automatically think of my father. It's really, really strange, and I'll tell you, it's a process that it's just instant and uncontrollable for the time it starts. And obviously, as I'm aware of the process, then I can bring my conscious mind into it and rationalize it. But yeah, if I was out the other day, I was listening to somebody, and they'd obviously been in the military, and they were talking about something. And all of a sudden, I was transported back to being a 7-year-old lad, and I had to kind of snap back. And I said to my wife, I said, it happens every time. Happens every time I hear anybody who's in the military talking, and it's really interesting because my next door neighbour's a former military man. When he speaks, I've had to really think to myself, Rory, he's not your dad, But that's the nature of transference, and of course the attachment it brings.
Such an important topic, an interesting topic. Yes, we can speak about it. And as Rory and I always say, we're not the experts here telling you what you should do or bringing you best practice. We're just two colleagues having a chat about these topics. And we encourage you to have a chat about these topics too. You can do that on our Facebook group. Get on Facebook, put in Counselling Tutor, come and join the group. Tens of thousands of like-minded individuals hanging out there having these kind of conversations. So moving away now from Digital Counselling Revolution, and we go into Practice Matters, where we look at something that is practice related for our qualified colleagues. And I believe we're going to be hearing from Martin Smith today, Rory.
We are. Martin Smith has done a fantastic lecture for our Counselling CPD library on working with personality disorders. And as you'll hear, presentation with people who've got personality disorders is quite high in therapy, and understanding and empathizing with people who have personality disorders is absolutely so important, because as you'll hear Martin speak, they are enduring presentations that clients have, and this is what he had to say.
Practice Matters.
So I'm joined by Martin Smith, who's done a fabulous lecture for the Counsellor CPD library on working with personality disorders. So Martin, thank you so much for joining me today.
Thank you for inviting me.
So the first question I guess that a lot of people may be asking and be interested in is, what is a personality disorder?
Yeah, there are a number of key points to this, and it's quite important to know a difference between a personality disorder and a mental health illness. Key characteristics are things like personality disorder has an enduring pattern. It's not something you have for a couple of months and then it disappears again. So it's not what we call symptomatic. It's characteristic. It's part of the person. It deviates markedly from a person's individual culture. So their behaviors and their attitudes are very different from their particular culture. And it's very pervasive and very inflexible. So a lot of people with personality disorder have a great deal of difficulty in flexibility and in dealing with problems. So it's quite pervasive. But the key point is it's not something you have for a few months and then it goes away again and comes back.
So it's an enduring part of the individual, as opposed to something that might be, sporadic, that comes and goes. Maybe like, shall we say, depression. I know people have depression for a long time, but people can have periods of it. But I'm guessing what I'm hearing is that personality disorders are enduring.
Yes, yeah. You could have depression for 3 or 4 months, and then, or you could go to a therapist and it can help you starting to relieve the symptoms of depression. But with the personality disorder, they're characteristic traits of the person. So we're managing that, not necessarily trying to cure them of it.
And I think that's the interesting position, isn't it? Because cure is sometimes used a lot in the world of counselling and psychotherapy. I hear my colleagues say, how do we cure a client? But I've just heard you use the word manage. So just explain a little bit about maybe the difference.
Yes, yeah. I mean, within personality disorder work, it's about trying to help the client manage their well, for want of a better term, their characteristic traits. Can we give them more coping mechanisms? Marshall Linehan in DBT talks about emotional regulation. A lot of therapies now do. How do we help regulate the emotional responses of, say, somebody with borderline personality disorder? So it's about helping them cope better rather than necessarily be better.
Yes, and I guess that could be a challenge for therapists who may find their skill set, I don't use the word lacking, but should we say ineffective when working with someone with a personality disorder?
Yes, definitely. This is sometimes just better understanding of what they're actually seeing in the therapy room can be a great help both to the client and both to the therapist.
Absolutely. And we just speaking before we recorded this, and you mentioned some statistics. You didn't have the actual statistics to hand, but you said that people with personality disorders are liable to be, you said 2% of the population, but might be up to 39% of people who present for therapy.
Definitely, yeah. There's the 1 or 2% of the population for, say, each of the different types of personality disorder could be there. But in the clinical setting, in therapeutic settings, you may be looking at a far higher percentage of people with a personality disorder. Obviously, they've got maybe other things going off, such as substance abuse, addiction, or depression. But underlying this could be some characteristic aspects which they need to be helped with.
Yes, and what are the kind of things that therapists struggle with when working with someone who presents with a personality disorder?
Well, I think the first thing is identification. For instance, you look at somebody with bipolar disorder, the bipolar condition, and somebody with borderline personality disorder, highly emotionally switching states, unstable moods quite often within borderline personality disorder, which can be sometimes mistaken for something like bipolar disorder. And therefore, we're trying to treat a condition like bipolar when actually it's sort of much more fundamental than that. It's a characteristic traits, misinterpretation. Classic one. Another classic is schizoid personality disorder, where you've got very low affect. The person isn't very interested in things. They don't get enjoyment out of things. Of course, that sounds exactly like depression. So we try to treat the depression, but actually it's just part of their characteristics. And so how do you help manage that condition rather than treat it?
Are there any telltale signs that a therapist may pick up? They may think that the client is presenting, as you say, with maybe bipolar or depression. But is there anything a therapist could do, maybe at the assessment, to kind of give them a clue if they're working with this enduring personality trait, or what can be a sporadic difficulty that people have?
I think you hit the nail on the head there, sort of in terms of like the difference there is, has this person had, say, the condition they're describing for a number of months or quite a few years, but how long has it been there enduring? So, I mean, obviously some clients will say, I have depression for 25 years and it's always been there. It's a typical globalization statement. But a lot of it is looking at where it pervades across all aspects of the person's life, and it comes down to this inflexibility. What I touch on a lot is the excessive trait or deficient trait that people with a personality disorder may have, and that's it shows itself quite broadly in their treatment.
It's interesting, isn't it? And what would you say the kind of pitfalls? I don't use the word mistake. I don't want to appear too judgmental, but what are the pitfalls that a therapist may find themselves in if they're not aware of personality disorders and how they present?
I think one of the biggest pitfalls that I've seen is boundaries. The person with a quite often a personality disordered person is far less boundaried and can often sort of overstretch boundaries considerably. Again, borderline personality is a classic example. I've supervised therapists who are trying to treat somebody they think has got, say, a mood disorder, but actually what they're doing is they're pushing the boundaries continuously, not hassling, but obviously contacting the therapist outside of therapy terms, and very often chasing them down for things.
Yes, so that could be an indication if a client is contacting you and they're pushing the boundaries, it may be an indication of a personality disorder.
And also the inflexibility, the fact that you've tried certain things with the client and there seems to be no shift. There seems to be no shift in what they're doing or how they're responding. And this can be a question of, is it the right technique or the right application, or more appropriately, is it characteristic traits that they've got?
Yes, absolutely. And I suppose as a supervisor, you have to work in the kind of restrictive area of supervision where you may get a supervisee who is really struggling with the client.
Very much so, yes. And also within therapy, you see a lot of, and people will often see a lot of clients who are actually struggling with somebody with a personality disorder. So the more likelihood here is that many therapists are seeing clients who are partners to somebody with a personality disorder. And that's where there's a lot of help could be by understanding what personality disorders are and how to appropriately respond to them could greatly help both the client and their relationship.
Yeah, I mean, I think that's a really, really useful observation. So you've done this lecture for us, which is absolutely fabulous. What do you think people will take away from this lecture, or what would you hope that people watching would take away?
I think the two key things are, one is the idea of what it is, the identification of some of the main personality disorders. So they've got an awareness. The key starting point is an awareness of what personality disorder is. The 10 main ones that we're going to talk about, and then just some general ideas about treatment or therapy work that might be appropriate to help with people with a personality disorder.
Well, I think, Martin, as you've identified, that roughly 39% of clients who present to therapists may very well have a personality disorder. This lecture is a must-see. So, Martin Smith, thank you so much for joining us.
Thank you very much. Thank you.
Thank you very much to Martin Smith. Thank you to you, Rory, for hosting that interview. And of course, if you liked what you heard and you want to hear more about Martin Smith, he did a complete lecture on working with personality disorders, and you can check that out in the Counselor CPD library. And if you're interested in getting more information on that, just go to counsellingtutor.com. All the information is on our website. So there you have it. What a episode, Rory.
Well, what an episode. We started talking about grief and a model of grief. We moved on to attachment in phone therapy. And then we finalised with that wonderful conversation I had with Martin regarding working with clients who have personality disorders. And as always, stay grounded, stay safe, and hey, join the Digital Counselling Revolution.
If you're a qualified counsellor or psychotherapist, then why not check out the Counselor CPD library? Stay current with your CPD requirements with over 150 hours of academically rigorous, on-demand lectures you can stream to your device. Joining Counselor CPD will expand your skill set to create a more specialised, highly rewarding practice. For more information on the Counselor CPD library, visit counsellingtutor.com.
Thank you for listening to the Counselling Tutor Podcast. Find the show notes for this episode on our website at www.counsellingtutor.com.